to the rapid fire orbital and oculoplastic surgery update session. My name is Akemi Iwasaki.
I'm Professor Neelam Pushkar from RP Center, AIMS, New Delhi. And I do oculoplasty and oncology surgeries for almost past 24 years.
Thank you. So we'll be chairing this session. She comes here to help me. Thank you. So we have 13 excellent presentation today, but I'm so sad, but almost half doctors can't come. So please enjoy our time, okay? So each with 5 minutes for the talk and 1 minute for question and answer. So before we begin, please note commercial names of medical devices, software, or equipment may appear in this session because they are linked to specific medical procedures. Other products on the market can also be used. The educational provider doesn't endorse any particular product. Okay. So let's begin. Our first presenter is Dr. Purnima Raju Karunikar.
Dr. Purnima, yeah, please come.
Please come. Thank you.
It's not open.
So it's a competitive session. So this is just for the presenters over here. 5 minutes will be given to each presenter and they will be marked for the presentation. Yes, Dr. Purnima.
Good morning, everyone. It's my pleasure to be here.
Can you give us the marking sheet over here, please? The sheet.
Okay. I'll be talking on comparison of external dacrocystorhinostomy versus injection botulinum toxin in the management of functional epiphora. I'm from Tilganga Hospital in Kathmandu. No financial disclosure and no conflict of interest. Functional epiphora or functional nasolacrimal duct obstruction is used to describe patients with epiphora with evidence of abnormal tear drainage, but where the nasolacrimal duct is partially or completely patent while doing syringing procedure. And in the same patient, when we do a fluorescent dye disappearance test, they are either delayed or absent. The Jones dye test 1 and 2 will be negative in these cases, and on normal dacrocystogram, if at all, if performed. So in brief, the patient will be complaining of watering and the syringing is patent, so there's an anatomical patency, but there is a lacrimal pump failure. So the management options, the most definitive one and the popular ones are DCR surgery, either endoscopic or open DCR. The DCR surgery helps in these cases because it breaks the three compartments, that is cul-de-sac, a lacrimal sac, a conjunctival cul-de-sac, the lacrimal sac, and the nasal mucosa into the two compartments. That is, directly the tear is drained from conjunctiva to conjunctival sac into the nasal mucosa. Hence, it negates the use of or the function of the lacrimal pump. So that's how DCR surgery helps in the functional epiphora. Some doctors just do a silicone intubation. It is thought that with the capillary method of drainage, it also helps in the functional epiphora. Some do lid tightening surgeries because with the laxity of the lids also, the lacrimal pump is sometimes found to be filled. And the most recent one, or the most popular one nowadays, is injection of botulinum toxin A into the lacrimal gland as an alternative to non-surgical method. Botulinum toxin is a neurotoxin. Its injection into the lacrimal gland blocks the presynaptic release of acetylcholine, which is required for the tear secretion, hence decreasing the tear production and thus minimizing the epiphora. The advantages are it is an easy procedure, outpatient, done in the outpatient department, less time consuming and minimal risk, but the disadvantages are it is temporarily. It has to be repeated every 5 to 6 months. It can cause dry eye and sometimes transient ptosis and diplopia. So we have planned to design a study. Since there are fewer studies in literatures, we have addressed about the outcome of DCR injection and injection of botulinum toxin in the management of functional epiphora. Most of the studies are isolated studies, either only the outcome of DCR or the outcome of injection. So we propose to do a comparative, to compare the efficacy of external dacrocystorhinestomy surgery and botulinum toxin A in the management of functional epiphora. It was a prospective comparative interventional study which included 45 patients with functional epiphora, out of which 20 had undergone external DCR and 25 patients received 5 units of injection of botulinum toxin in the palpebral lobe of the lacrimal gland, and the choice between the surgery and the injection, we left it for the patients to choose. So we put first topical anesthetic drop. Then we took 5 units of botulinum toxin in 1 ml syringe and used 27 gauge needle and asked the patient to look down and in when the palpebral lobe is exposed, and we give with a single shot of injection. All the patient underwent syringing and fluorescent dye disappearance test before the procedure, and then also after the procedure. The epiphora was also graded subjectively by doing a Monk score obtained before and after the intervention. So in the Monk score, no epiphora is actually 0. There's a little typo error. No epiphora is 0. Occasional epiphora requiring drying or dabbing for the tears less than twice a day. 2 is epiphora requiring dabbing 2 to 4 times a day. 3 is epiphora which require dabbing 5 to 10 times a day. And 5 is epiphora which dabbing multiple times in a day. In the results, the mean age in external DCR group as well as the injection, botulinum injection, was similar, that is late 40s. And out of 45 patients, 32 were females and 13 were males in the ratio of 2.4 is to 1.7. In the laterality, the right and left eye was almost equally involved, but please note that there were 9 patients had both the eyes involved, and then those 9 patients opted for the injection. Hence, there were 45 patients and 54 eyes involved in this study. So this is a graph showing the Monk score. The right-hand side is a DCR group, and the left-hand side is the injection group. The x-axis showing the percentage, and the y-axis showing the Monk score at different before intervention and then serially after the intervention. So before intervention, you can see that in both the groups, the patient had a grade 4 Monk score, that is increased watering, while in the 7th day, the injection group had significant improvement, which is showing the green line, while the DCR groups, they still had some watering, while in the 6 months, the DCR group had improved the persistent and improved Monk score, while the botulinum toxin group, she had only 55% had grade 1, and then 35% had a 0 Monk score. That means maybe there was a weaning off of the botulinum toxin injection, and the patient might require new injection. The Monk score before and after intervention was statistically significant, less than, with p-value less than 0.05, which shows there was improvement in epiphora in both the groups. The FTDT was obviously positive in dye in all the eyes before intervention, and after intervention at 6 months follow-up, 95 eyes in external DCR group and 91% eyes in injection group had no retention of dye. The complication of DCR surgery was similar to any other DCR done for other indication, while complication in botulinum group, there were 29% eyes have dry eye at the end of 6 months, and 2.9% had transient diplopia lasting 3 weeks, and 2% had subconjunctival hemorrhage, and then 5% of eyes had transient ptosis, which lasted for 4 weeks as early complication. Hence, the overall success rate in both the group was not statistically significant, with p-values of more than 0.05%. That is 95% success rate in group A, that is DCR group, and 91% success rate in injection group. Hence, since both the groups have similar successful outcomes and that botulinum toxin injection is more favorable and convenient, the injection botulinum toxin can be considered as an alternative management in cases of functional epiphora for patients who do not want to undergo surgical intervention and for those with comorbid conditions with high risk for surgical intervention like DCR. Thank you for your kind attention.
Thank you, Dr. Purnima. So, does anybody have question?
I'd like to know how often it has to be repeated and also long-term.
Yes. For
Mike, please.
She's asking how many times the patient got the repeated once and the long-term outcome. So, for generally when we give a botulinum injection for blepharospasms and all, we need to repeat every 3 to 4 months. But for these cases, we repeated the injection after like 6 to 7 months only, and also not for all the cases. For this study, we followed up for 6 months only, but even out of the study also, when the patient comes, they come after 8 to 9 months or even 1 year for just injection. Because when there's a little bit of watering, we tell them, if you have just a little bit of watering, no need to come. If you are like just disabled due to watering, then only we give injection. So it has like 6 to 7 months, I should say.
So what was the underlying etiology in your study?
The
Functional epiphora.
So in our study, the syringing was patent in all the cases. So we diagnosed as
Underlying pathology, was it aging or facial palsy or what exactly?
no, we didn't take all those cases. With the aging, we took for all the adult age groups, and the most common age groups involved were late 40s, around 50s, and then we excluded the Bell's palsy and all, and just took the functional epiphora, which was present naturally with the age, and we also excluded ectropion and all those cases also.
So wonderful study, I must say, because
Thank
this
you.
is very complex area to deal with. So when a patient with functional epiphora comes to us, even for us, it's difficult to counsel the patient because we have to give all the treatment options to them. So if you have to give now, after doing this study, which option you will give to the patient first? Because we can tilt the patient's mind according to what we feel is the better for the patient.
In our setup, we first ask where the patient is coming from. If they are coming from far off places and they are coming to hospital for the first time and they cannot come for follow-ups, we counsel for DCR surgery. But we ask them, can you come at least 6 months for follow-up, because we might need to give the injection, then we give for the botulinum injection.
Okay, so basically in my experience, if patient is very old, say 70 plus or 80 plus, so generally I tilt the thing towards the Botox injection rather than going ahead with the surgery, because surgery is a major thing,
Yes.
But definitely it's a permanent solution.
Yes. And also, because of the complication, we avoid doing, like you said, DCR surgeries for patient more than 65 or 70. That also is there.
That's right.
Yes, ma'am.
Thank you so
Yes,
much.
ma'am.
It was
Thank you.
really very insightful presentation.
Thank you, ma'am. Thank you.
So I just want to announce that this is not a competitive session.
Okay. Thank you, Dr. David. So please welcome Dr. Hai Chien Ha, who will present causes of failure after primary DCR detected on endoscopic follow-up of osteum.
Good morning, everyone. I'd like to present our outcomes on the causes of endoscopic DCR on the primary surgery in our case series. As everyone knows that endoscopic DCR is considered as the first line for primary nasolacrimal duct obstructions for many oculoplastic surgeons, especially in the Asian Pacific area. So the endoscopic for the oculoplastic surgeon now is not only a surgical instrument, but it's also a pre-operative and a post-operative monitoring tools. With the availability of the wireless device like I've shown on here. These are the device that range from $10 to $100 that I have searched on a on a searching engines. It is very available to us. And on the endoscopic monitoring, we can find many like causes for the failure case, and it has been reported by many authors, such as membranous obstruction, granulation, adhesions, shrinkage of the osteum, and the osteum fibrosis. So this paper is aimed to describe the failure rate changes along the 12 months of following up in our series, and we'd like to discuss the causes of failure that we detected on endoscopic evaluation of the osteum. This is a case series, no control roof on 84 cases of primary nasolacrimal duct obstruction without any other eye or maxillofacial diseases. All the patients underwent first-time endoscopic DCI with cold steel techniques and mucosal flap marsupialization and performed by one surgeon and controlled by one surgeon. The follow-up time is 12 months. So the anatomical outcomes defined at the patent lacrimal passage while performing irrigation, and the success is classified good if you had a completely passage, and fair if the lacrimal passage is mostly patent with a very small reflux, and a failure is defined. We have a total reflux from the same or opposite punctum. The following up visit 1 week, 1 month, 3 months, 6 months, and 12 months with endoscopic examination to evaluate all the osteum status. And these are our results. 1 week after the surgery, we have 98% of success on anatomical evaluation. But these rates decrease at 1 month and 3 months, and from 6 months onwards, it was stable at 87%. And our mean time to recurrence in the 11 cases of failure was 14 weeks, which means about 3.5 months. In our series, about 87% of the patients had good results at 1 week, but this number also decreased over time to 78% at 6 months, and after that it didn't change significantly. For the analysis of the causes of failure in the 11 cases of failed case in our series, we found that 100 of the failed cases have fibrotic totally or mostly of the osteum. And the second most popular cause is canalicular obstruction. It was this so common canalicular obstruction, and other causes was rarer, like adhesion or granulation of the osteum and some syndrome. So in our series, more than 63% had more than one causes of failure. And the most common combination is the fibrotic scars of the osteum and the distal canalicular obstruction. In order to analyze the characteristic of the osteum, I present the characteristic of the whole series now here. And in our series, about more than half of the patients had a small size of the osteum, maybe because we use a cold steel technique, and in this technique we couldn't like open very high over the internal common opening of the canalicular, and all of the failure case has a unrecognizable or a very small osteum, and it's the same about the shape of the ostium. All the failure case had a unrecognizable shape or a very narrow vertical slit. On the evaluation of the internal common opening of the canalicula, all the failure case has a untraceable ICO or a partially obstructed ICO. About the cicatrization of the ostium, at the final follow-up, we've found that all the failure cases will have a totally complete cicatricial closure of the ostium, or a mostly cicatricial closure, like you can see on the slide. In the last follow-up, we saw that we have about 3.6 adhesion of the ostium, and the granuloma was seen in 2.4% of the series. So the features of the ostium that we found is significantly relative to the success was the shape, the size, the cicatrization of the ostium, the adhesion, the movement, the dynamic of the ICO, the stand, and the overrating of the ostium. So in our series, the causes of failure, the most common was cicatricial closure and associated features of the ostium, like shrinkage or abnormal shape of the ostium. And normally it has an involvement of the distal canaliculi or common canalicula. Rare causes was granuloma and adhesion. So we found that endoscopic assessment of the ostium was necessary in follow-up, especially for the care for debridement and detect early risks of recurrence, like granulomas or synergy and cicatrization to act promptly, such as medication or to burn the granulomas. And it can help surgeon to evaluate surgical technique effect and change the technique if needed. So in our series, we found the success was stable after 6 months. So routine follow-up of the ostium was necessary at least 6 months after the operation. And the most common cause of failure was the ostium cicatrizations. Thank you.
Thank you, Dr. Har. Does anyone have a question? Any question?
So, Doctor, it was a wonderful presentation, I must say. So, like Rimal system, we all know is almost like 1/3 of our patient load in the clinic. And once we come across complications, especially the failure of DCR, then it becomes little difficult. So it was a wonderful depiction of all the complications which you have shown. But I was wondering if any secondary intervention did you try in patients with Synechiae or in patients with fibrosis of the ostium?
Yes, if I had an adhesion, I did try to separate the adhesion, and after I give a steroid. A nasal spray steroid after the separation of the adhesion. The same with granuloma. I'd give a nasal spray steroid and steroid drop first. And if it don't resolve in about 2 or 3 weeks, I do a cut by a bipolar burn, and after that I give a steroids too.
Okay. Routinely also you gave steroid after the DCR surgery, nasal spray?
Yes. Nasal spray for about 1 month and drops for about 2 weeks.
2 weeks?
Yes.
Okay. All right. Thank you so much.
Thank you.
Very nice presentation.
Thank you very much. So our next speaker is Dr. Kamlan Kevin Chang.
Thank you very much for the introduction. I'm actually presenting on behalf of my fellow, but we own the cohort together. So we were talking a very different concept on thyroid eye disease from our Hong Kong thyroid eye disease cohort. There's no financial disclosure relevance to this. I'm going to skip this because I'm sure the audience are all experienced colleagues from Oculoplastic. Most of your work, I'm sure you'll be seeing thyroid eye disease patients. I just want to draw your attention to a very recently published paper. This is one of the longest paper we try to submit. It keeps getting rejection. I can understand why. Because we were challenging a concept that has been used for ages, clinical activity score. And we were telling the story from the Hong Kong side. Around 1,500 patients, consecutive untreated patients, who we think that actually doesn't follow the Rondo's curve. It's a low-CAS progressive disease. 38% actually presented with moderate to severe disease according to the UGOGO severity. They have very low CAS score, and even those 150 cases that has visual threatening thyroid eye disease, which is done, and again, the clinical activity score is below 3. So low CAS. If these were clinically inactive, what do? You do nothing. I mean, you do surgery, of course, but you do no medical treatment. For these, we are able to identify that, in fact, these were clinically inactive but radiologically active. I'm going to show you the methodology. For these low CAS patients, they respond. I think that's the key thing. Low CAS, progressive disease, as long as you demonstrate radiological activity, they actually respond. And I'm going to be practical. In this free paper, I'm not going to talk about the fancy scan. Just a simple T2 fat suppressed sequence. It's non-contrast, remember. Non-contrast, the radiologists like it. It's cheap. They don't have to be around the scan time. They don't need to even insert the cannulation for contrast. The STIR sequence is a classic a sequence that is T2 fat suppressed. We are only concerned one thing. Is there any inflammations, okay, in the orbit, even though clinically it's not. So for East Asian, I'm sure it's not just East Asian. Non-Caucasian, let me put it this way, or skin of color. I think most of our patients with our eye disease actually presented low CAS progressive. That's why we were looking at the CAS and the RAS, radiological activity score, in this study. So this is a cross-sectional study, all the treatment-naive ethnic Han Chinese thyroid eye disease managed by our university. They have a baseline MRI scan, and the STIR sequence is the sequence of interest. And of course, the clinical and serological profile. Among the large series, we just do this, 188 patients, and these were the background informations, very typical, 6% are euthyroid. We also published on this earlier on. And the correlation between the clinical activity score and what I meant by radiological activity score is weak. There is correlation, but it's not strong. So the correlation is pretty much similar between different extraocular muscle. We also look at the levator superior rectus complex. And the correlation between clinical activity score and radiological activity score becomes stronger if you are clinically active. I repeat myself, the correlation is there. It's weaker if you're clinically inactive, 2 or below. Stronger if you're 3 or above. That makes sense. The MRI is just showing what you've seen clinically, but at a much lower threshold to detect the inflammation inside the deep orbit. And this is what we were trying to look at. And I think these, again, as expected, there's no correlation between the clinical activity score with the thyroid profile, and this is just thyroid function, as well as the TSI. TSI is the antibody. I don't think serological profile works. I mean, very helpful in eye disease management. It's useful overall management for the patients, but not for the thyroid eye disease. So I'm going to summarize now. The key results is there is correlation between clinical activity score and the STIR sequence. There are many other sequences, but I think the cheapest and easiest way to look at it is the STIR. STIR is just simply a T2-weighted fat suppression sequence. You're looking at water. If you're looking at the water inside the orbit, usually there are only two causes, inflammatory edema or vasogenic edema. It's not the brain. Vasogenic edema is not common. So we are essentially looking at water contents, lacrimal gland muscles, most commonly likely to be related to progressive thyroid eye disease. The correlation becomes stronger if clinically active. I mean, as a score over 3. The correlation is poor between the MRI and the serology. we are trying to put up some of the information here from the Chinese series, excuse me, from outside of our series, both in UK, Japanese, and Chinese. And I think the correlation is stronger somehow, but at least in our cohort, the correlation exists, but it's kind of low. Low CAS progressive disease patient, I think the message here is these patients actually respond to medical treatment, which is not listed in all the existing UGOGO or ATA-ETA consensus. Of course, this is just a single center study. I do believe that the Asia Pacific region, APAO, AP stoppers, is the avenue where we can join hands. I don't want fancy sequence in that sense. I want to be practical. A non-contrast T2-weighted fast suppressed sequence or a stress sequence or some other sequence of the similar nature should be able to get the message across. And of course, there are limitations because it's an extended study over 10 years. Some of my fellows actually do the exam, but they were personally trained by myself, so I'm pretty sure we're pretty consistent in that sense. Thank you very much.
Thank you, Dr. Chang. So does anyone have any questions?
Yeah. Any questions?
Oh, yes.
Excellent work, Kelvin, as usual. Just a question that is there a reason why? I mean, we know about the let's say the stir sequence, but there's also a talk about T1 and T2 relaxation times being effective. And since you're working on this, do you think they are better? They are not as good, because there's quite a bit of talk about several parameters in MRI that could actually give you more than what the clinical evaluation does.
I'm going to bore everyone here. T1, T2 relaxation time, the DWI sequence, these were functional sequence, and also the dynamic contrast enhancement. The diffusion, the perfusion, the relaxometry, these were the high-end thing. These were fantastic. Works better than T2 fast suppress. But these will significantly extend the scan time. Our research scan, 45 minutes. Very expensive. It's not practical. I don't want to talk about this here. I want to be practical. Five-minute scan. That's it. No contrast. 5 minutes. I think this is something that is doable. I'm sure if you can you bundle this with your MRI center, you send them cases, make them cheap, practical, you make a decision. All these fancy scans, I'm sure it's more sensitive, it's more specific as well, but in the setting that you actually want to initiate therapy, but you don't want to go off-label. I'm doing it to protect us because we're going off-label. To give steroid in a clinically inactive patients, progressive disease, I'm protecting myself, and I hope that concept makes sense to you. There are a lot of work on MRI that can be done. I agree with you.
And, just a quick one, do you any longitudinal work to show how much of change? Because the best part about the whether you talk about the signal intensity or is that it actually tends to show a change when you do therapy, and it tends to show much better. So what is the threshold and how much? Any work on that?
We're working on this. You're very correct. Longitudinally, the short answer is longitudinally they improve in terms of the size of the muscle and the signal. That's an easy way to remember this. The water signal, the inflammatory signal, and the size improve, but they never actually go back really to normal. So that's the signature of it. I kind of like this. So you know this patient actually has disease before, but like an RPE changes. You know that if something happens, but it never goes back. I don't have the threshold for you. I need more data. I really want to recruit people to join me on this. I really think that a CAS-independent approach is what we need here. We should not be limited by CAS, but we need some evidence. I think MRI, a non-contrast, cheap MRI would be good.
Thank you, doctor. This is very challenging area which you have touched upon. So routinely in your practice, do you now prefer you doing MRI as a baseline even in patients with zero CAS score?
The key point is, do I think these were progressive patients? If our patients only have mild lid retraction, just some dry eye, they have the money, yes, they can do it. But I'm not too concerned. If I want to initiate immunosuppressant, that's the key indication. I think this patient needs treatment, but it's low CAS, and it's not done. So what am I going to do? Wait until they deteriorate? No, I'm going to do an MRI scan, convince them. If there is a RAS positive, a high radiological activity, That justifies my treatment.
Okay, all right. So you recommend all patients?
I would. Of course, if you already have like CAS score of 4 or 5, you can do it. You show a lot of inflammation, but you don't need to do that to protect, at least justify our treatment. I think the treatment is the thing that I really look into.
Okay. Thank you, doctor. Thank you. I don't know, you have to listen. You can invite the other one. If that person is here, then you can.
So is there Dr. Vijay Langarajan? No? Okay. And Dr. Jing Gwen Ding? No, maybe no.
No.
Visa issues or
Yeah.
something, okay. So I will now present my own talk.
So I'll do the honors, of inviting you for your paper. This is on a gel-assisted extraction technique for lacrimal canalicular stones.
Okay.
Looks interesting.
Thank you.
Thank you, Dr. Akemi.
Thank you. Hello, everyone. My name is Akemi Iwasaki, and I'm from Japan. Today, I'd like to talk about a new technique I've developed to treat canaliculitis, the gel-assisted extraction technique. I have no conflict of interest to declare. Treating canaliculitis is not always easy. It is often difficult to completely remove all of the canalicular stones. Incomplete removal can lead to recurrence. That's why I developed a new method to remove stones quickly. Thank you. I had a step. Okay, thank you. and more completely, okay? So first, let's talk about the gel. The type of gel that can be used safely near the eyes may vary by country. We prefer a gel with a pH between 6.5 and 7.8, close to that of natural tears. Now the technique. We start by performing a standard one-snip punctoplasty. Using scissors, we make about a 5 millimeter incision on the nasal side of punctum. Then we manually express the stones using forceps, cotton swabs, or simply the fingers. Now, let me explain the key part, the gel-assisted extraction technique. We insert an 18 to 23 gauge catheter through the punctum and advance it as far as possible towards the common canaliculus. Next, we inject about 0.5 milliliters of lubricant gel or lidocaine jelly. The gel expands the canaliculus more than saline and provides greater pressure, allowing the stones to be expressed through the punctum together with the gel. Similar to the visco expression technique used in cataract surgery. We repeat this step until no more stones come out. Here is a video of the actual technique. Once no stones come out with manual pressure, we inject the gel, and as you can see, a large number of stones are expelled together with the gel. If possible, we perform dagger endoscopy afterward to check for any remaining stones. The canaliculus is often dilated and contains numerous polyps, unlike the normally narrow one. We reviewed 8 cases treated with this technique. In 1 case, a stone remained near the punctum. In 2 cases, stone remained inside the canaliculus, both of which had canalicular obstructions. Here is case 8. The patient had a common canalicular obstruction and a stone was left before the blockage. This suggests that when there is an obstruction, stones tend to remain behind the blocked area. There are some limitations. First, we must ensure that the gel is safe for ophthalmic use. Second, during the patient interview, we need to check for any allergies to the gel components. And finally, in cases with canalicular obstruction, residual stones may remain. If possible, we should open the obstruction and consider placing a stent. In conclusion, the gel-assisted extraction technique is a simple and effective method for removing the canalicular stones. Thank you very much for your attention.
Thank you, Dr. Kemi. It was wonderful presentation. And this is again a very difficult area to treat. So sorry I missed the initial part of it. Did you give any nick also in the canalicular system before expressing the stones out?
I'm sorry.
Did you give any cut, any incision in the vertical canaliculus or the horizontal one also before expression of the, because sometimes, you know, it's a very small puncta and expressing it out is difficult. So did you give any snip over there? Any combined snip procedure before expression?
Oh, usually I just cut from.
How you cut,
Yeah,
no?
yeah.
Okay,
just
you cut
from
and
the
then you
punctum.
express it.
Yes, that's right.
And from in the same system, you place your cannula and you inject the gel, right?
Oh,
And
yes,
then
that's right.
express.
Yes.
Okay,
Yes.
all right. It was wonderful.
Thank you very much.
Thank you. Any questions? This is again a very challenging area, so you people can also, you know, express your views over the thing. It's a rare entity, so whatever you have come across and the way you have managed, you can always come forward and, you know. Did you do syringing to check whether the nasolacrimal duct was patent or not? Did you do syringing after the procedure? She did dacrocystoscopy, no?
Yeah. Usually I do the dacryl endoscopy before and after the.
Any syringing did you do to check the patency of the system?
Yeah, actually, when there is many stones, sometimes even the common canalicular or some canalicular is open, the syringing that doesn't go. So it's not right. So after taking out removing all the stones, and after maybe few days, after the inflammation is down, the real syringing test is come true.
Did you check for any epiphora after the procedure?
Actually, but
any of your patients had epiphora after the procedure?
No,
they were,
no.
all free
Even I cut big, no epiphora.
Okay.
Yeah.
Even I have done, you know, in my patients, those who are resistant to conservative treatment. So I do the canaliculotomy procedure, open the, you know, the vertical and the horizontal part of the canalicular system, and extract the concretions out of it. Because these are very chronic, you know, patients, and generally they don't respond to the topical treatment or any flushing procedure. So you have to cut the system, and after that, whatever cases I have done, because it's a rare thing, you know, so they never complained of any epiphora. So that is a good thing. And plus, I don't do any kind of intubation because the system is all open. Thank you so much, Dr. Kim.
Thank you very much.
Oral or topical you are talking about?
Sometimes I use the topical, but usually I don't use so much. Just for the eye drops, that's all.
Even I give only topical, no oral. Because once the system is all flushed out, generally it will not come back. That is also described. So once you do all these things, then you know that it's not going to work, then you go ahead with surgery. So like surgery is the last resort kind of thing. Thank you.
Thank you very much.
Okay, you can invite the other
Okay.
one. The after
So,
you.
okay, so our next speaker is Dr. Pauline Andrea Wong, presenting rare eyelid schwannoma in a 5-month-old infant. Thank you.
So good morning. Good day, everyone. I am Pauline Wong from St. Luke's Eye Institute from the Philippines, and I will be presenting a case of schwannoma of the lower eyelid resembling a recurrent chalazion in a 5-month-old infant. So I have no conflict of interest. Okay, so a 9-month-old girl came into our clinic for a 4-month history of a slowly enlarging mass on the lateral third of the left lower eyelid. So actually, the patient's mother first noted a pinpoint non-erythematous lesion on the lateral third of the left lower eyelid, and this was initially treated as a chalazion by her pediatrician with oral cephalexin and erythromycin ointment, but no improvement was seen. So then the patient was referred to an ophthalmologist where an incision and curettage was done, and then the curettage revealed yellow gelatinous material, but lacked any histopathologic analysis. So 1 month later, the mass enlarged even further, ulcerating at the anterior border, prompting further consultation. So this was the patient on the day of consult in our clinic. And so here we can see an 8 by 12 by 11 millimeter non-pigmented, non-tender, multilobulated, movable anterior lamellar mass with well-defined borders and slightly prominent vessels at the 3 and 9 o'clock. So it is important to note that there was normal lid margin in this patient. The palpebral conjunctiva and the posterior lamella was intact, and the eyelid margin was also intact. And there was no lagophthalmos, no poliosis, no matarosis, and no large feeder vessels. So the plan was to do complete excisions of the lesion with areas of normal tissue. So the surgical excision was performed via a subciliary approach. So intraoperative findings revealed a light yellow to brown, firm, encapsulated lesion with solid and cystic areas with attached skin measuring 8 by 12 by 11 millimeters. Histopathology also revealed these patterns of Antony A and Antony B, and also spindle cells were seen. Immunohistochemistry was positive for the S100 stain, the SOX10, and the TLE1, while it was negative on the following stains. So owing to the positive stains of the S100 and the SOX10 and TLE1, immunohistochemistry thus confirmed the diagnosis of cellular schwannoma with plexiform features of the left lower eyelid. So moving on to the case discussion, actually schwannomas are benign encapsulated, slow-growing tumors of the peripheral and cranial nerves. And these tumors occur usually in the head, the trunk, and the extremities, but eyelid involvement is extremely rare, typically originating from the supraorbital nerve, supratrochlear, or the infraorbital nerves. And to date, only 4 cases of eyelid schwannoma in children have been published so far. So we present the youngest known case of eyelid schwannoma in a child. Okay, so these are the previous case reports of eyelid schwannoma in children. We can see that our case is the youngest, diagnosed at presenting at 5 months old, and she also had the shortest duration of symptoms of 4 months compared to the others who had the lesion for about 2 to 3 years. So note that none of these patients had any associated neurofibromatosis because 90 to 95% of schwannomas are sporadic, meaning that they occur without any genetic condition. So about 5 to 10% of schwannoma is associated with neurofibromatosis type 2. And we also note that similar to our case, diagnosis was confirmed with a strong reactivity to the S100 stain, and which is considered a hallmark feature of schwannoma. So at 13 months post-op, the patient had good wound healing with no palpable mass, no granuloma formation as well. And to conclude, eyelid schwannoma is a possible differential in a child with an eyelid mass. And similar to the 4 other published cases, the eyelid schwannoma in these children is isolated without any syndromic or systemic associations. And to our knowledge, our patient is the youngest patient to have eyelid schwannoma reported in literature. Okay, so these are my references, and thank you for your attention.
Thank you, Dr. Warren. Any questions?
So this was a very interesting, very unique case, I must say. So I think the take-home message is that if you are doing any, kind of intervention for some unusual presentation, like we don't see callusion in this age group.
Yes, that's true.
So if we are doing any kind of intervention, we should send for histopathology in the first sitting itself. So there was one intervention you said, no, was done before the mass excision.
Yes.
So that time histopathology was done?
No, histopathology was not done for the first incision and curettage, yeah. So the mass
any
grew.
unusual case, any unusual presentation, if we are doing any surgical intervention, I feel the histopathology is very important thing. So that time itself we could have picked up.
Yes.
No, right? Very nice case. Thank you. So
Thank
much.
you.
Thank you.
Thank you very much. So is there Dr. Yining Wang? Yining Wang? No? Okay. So, so next up is Dr. Yasushi Fujita. His presentation is titled Impact of Orbital Thorium Syndrome Injections on Eyelid Position in Thyroid Eye Disease. Okay.
Thank you. So my presentation is impact of orbital thorium syndrome acetonide injections for thyroid eye disease patients. Let's see. No financial disclosures. So, thyroid eye disease patients have facial changes such as upper and lower eyelid reaction, leading to psychological stress. So, in this study, we assessed the changes in eyelid position following orbital injections of thorium acetonide (TA) for upper and lower eyelid retraction. So, this study included consecutive 40 eyes. TA 1 milliliter was injected percutaneously and vertically into the orbit using a 30 gauge needle, 30 millimeters I use. And TA was injected once a month until no further improvement. And we assessed the degree of improvement of MRD1, MRD2, the exposed ocular surface area, and the proptosis. This is a procedure. The needle is inserted percutaneously and vertically from the orbital rim into the orbit. 20 milligram TA was injected to the upper and the lower eyelids respectively. So this is our result. So as you can see, MRD1 and the eyelid area showed significant improvement. On the other hand, no significant improvement was observed in MRD2 and the proptosis. And additionally, a positive correlation was found between MRD1 and the eyelid area. So these are cases before and after treatment. So there is a clear improvement in upper eyelid reaction and swelling. MRD1 and the iris are obviously improved by orbital injections. So So let's go to a discussion. The injection areas are generally shallow and the steroid may not adequately reach the orbital region. We believe that vertical injection from the orbital limb allows the steroid to reach deeper inflamed areas more effectively. So, an applied reduction and swelling are considered overactivity of the mular muscle, inflammation or fibrosis of the lateral muscle, and the fat around the eye. So, we have found that orbital steroid injections are very effective in these conditions. However, there are some cases orbital steroid injections are insufficient for MRD2 and the proptosis. So we believe that orbital decompression is unnecessary as a next step. Since orbital decompression is transconjunctival approach by LER release and fat removal from the inferior part of the eyeball. That's why fat depletion is effective for MRD2 and the proptosis rather than orbital injections as seen in this case. So, therefore, we believe that attempting to correct eyelid reduction as much as possible with orbital T injections, followed by combining orbital decompression surgery, can achieve higher patient satisfaction. Conclusion: orbital T injections are effective for improvement of eyelid reduction and orbital fat inflammation. Low eyelid reduction and proptosis often require orbital decompression surgery, and it's important to consider combining TA orbital injections and orbital decompression surgery for cosmetic treatment. Thank you for your attention.
Thank you, Dr. Fujita. So, is there any question?
Yeah. Yeah, sometimes intraocular pressure is going higher. So in that case, I usually quit the injections.
So in other words, like in which plane you inject the steroid? In which plane do you inject the steroid? It's above the LPS or it's extracorneal, intracorneal?
LPS?
Yeah, which plane? Which plane you are injecting it?
It's like an intracorneal space. So
Intracorneal
like
space?
a fat inflammation. Actually, like intraorbital space. That's why for fat inflammation and LPS like inflammation. So like these are the point to inject.
Okay. Thank you so much. It was really wonderful presentation. Thank
All
you.
your patients
Yeah,
had
and
active
there
eye
is one.
disease.
Sorry?
Were they on, all your patients had active eye disease. Were they on oral pulse steroids as well? Oral or IV pulse steroids?
Sorry?
She's asking about the CAS score. All your patients were CAS score, clinical activity score of
Yeah,
the
over
patient.
three,
They were
over three.
like clinically active, or
Yeah.
they were
This
non-active.
case is all of the like active cases over CAS score 3.
No, if they were also on oral or systemic steroids, would that also?
Were your patients on pulse steroid also?
Steroid.
Pulse
Pulse?
steroid or
Yes,
intravenous
yes,
steroid?
yes. Simultaneously, some cases are do steroid
Some
pulse
cases.
treatment.
Okay.
Yeah,
Okay.
I have to get rid of it, but yeah,
Okay.
combine.
Okay. Thank you so much. Yeah, there is one more.
What is the, may I know the syringe that you, the needle that you use in injecting? Is it 1 inch or 3/4?
12 millimeter. 12 millimeter.
And then
27, 27 gauge. Oh, sorry, 31 gauge.
31
Huh?
gauge.
31 gauge.
31 gauge.
is very,
And-
very small one
And 12
Yeah.
millimeters.
because avoid like
Uh-huh.
intercorneal bleeding.
Yes, very small.
He said active stage.
Yeah,
That's what he said.
that's a consecutive active stage. Yeah.
Any other question? It's very interesting topic actually, and quite debatable also. Yes, yes, sure.
It's very much related to what Calvin was talking about, and it makes sense. So if you go by CAS score and you try to use triamcinolone for upper eyelid retractions, then you could possibly have difficulty in differentiating who to inject and who to not. A better way to actually is extrapolate what Kelvin talked about and look at MRI. Typically the sagittal images are very good. And if you see a high signal intensity ratio in the LPS, SR-LPS complex, then those are the people who would benefit a lot. That's what
Yes,
is known.
yeah.
The others who don't show that, really, I mean, some literature tends to say that even steroid injections into the muscle helps in those ones who don't show a high signal intensity also.
Yeah.
But that one, is the anti-inflammatory effect of steroid helping, or is it just like a spacer? We really don't know. But definitely the ones where the signal intensity is high on MRI, on imaging, are the ones who likely to benefit most from triamcinolone injections. Yeah.
Yeah, rightly said. Thank you, doctor, for your inputs. Okay, thank you so much. Thank you.
Thank you very much. Thank you, Dr. Fujita. So next speaker is Dr. Jang-hee Lee. Is he there?
Good
Can you
afternoon,
start the
everyone.
video, please?
Thanks
video,
for
please.
attending my
He has
presentation.
uploaded his
Today,
video.
my topic
Physically,
is
probably he is
unilateral
not here.
hypoglossal nerve
Started?
palsy
Good.
after repairing a fractured ligamental complex. Let's move on the case. The patient, a 32-year-old male, sustained an injury while cycling and was admitted to our center for treatment. Orbital CT scans revealed a fracture of the left ligamental complex. Consequently, we proceeded surgery under general anesthesia. The anesthesia and the operation went uneventfully, and the surgical results are good. But at this point, the patient complained about new symptoms, including slurred speech, difficulty in chewing and swallowing, and episodes of coughing while drinking. The patient was unable to move the tongue to the right within the oral cavity. Upon attempting to extend the tongue, the tip deviated to the right, and there is swelling on the tongue's right side, as we can see in the picture. Despite these issues, there was no tongue numbness, altered taste, or pain in the oral cavity or throat. So what happened to the patient? MRI and laryngoscopy ruled out both acute cerebrovascular accidents and a cricotinoid joint dislocation. With input from a neurologist, detailed assessments pointed towards hypoglossal nerve palsy as a possible diagnosis. The hypoglossal nerve, it plays a vital role in controlling tongue movements, facilitating speech, chewing, and swallowing. Although rare, hypoglossal nerve palsy after general anesthesia is quite challenging in clinical. To date, we have insufficient understanding on it.
Check the audio, please.
Then we conducted a search on PubMed and identified 52 case reports in English. In comparison, 57 patients who experienced hypoglossal nerve palsy or type syndrome after general anesthesia. Notably, 42 of these patients were male, indicating a marked gender disparity. The surgeries were predominantly performed on the shoulder, upper knee, and oral maxillofacial regions. Among the reported cases, endotracheal intubation was employed in majority, with oral intubation outnumbering nasal intubation by a ratio of 38:5. Supine and beach chair position were the most commonly used, during these procedures. Symptom onset predominantly occurred in the early postoperative period. The precise mechanism underlying this complication remain unclear, but outcomes of literature reviews indicates 4 primary factors warrant consideration. First, improper management during anesthesia can result in hypoglossal nerve palsy. Second, while surgical procedures may play a role, direct damage to the hypoglossal nerve during surgery is rare. The elevated proportion of shoulder, upper limb, and oromaxillofacial surgeries exceeding 60% suggests a potential association with a close anatomical proximity to the hypoglossal nerve. Furthermore, anatomical factors have been proposed as a possible explanation for the notable gender disparity in these cases, although the limited number of cases restricts current literature on this topic. Lastly, local punctures, vascular injuries, or even viral infections can also contribute to the onset of nerve paralysis. That's all. Thank you for your listening.
Good afternoon.
Thank you. So we move on next speaker. So, okay. So, please welcome Dr. Preeti J. Abbao, speaking on cost efficiency comparison between endoscopic and non-endoscopic endonasal duct rhinostomy. Right?
Thank you, Professor. Good afternoon, ladies and gentlemen. My name is Preeti. I'm from Singapore. As opposed to all the other talks that we have heard about for the last 1 hour, which compares clinical outcomes, mine is a bit different. I'm going to look at financial aspect of things. So the topic is the cost effectiveness of non-endoscopic endonasal DCR done at the tertiary hospital in Singapore. I do not have any conflicts of interest. So as we all know, DCR has taken a long route starting from external traditional approach, and recently with the introduction of better visualization with endoscopic instrumentation, this endoscopic DCR has taken an upper hand, and usually it is undertaken as a combined procedure between an ENT and an eye surgeon, and it always involves expensive instrumentation. So we're going to compare this with the non-endoscopic approach. So what exactly is this approach? The one that we use in our hospital was introduced by a surgeon who underwent a fellowship training under Dr. Peter Dolman and was introduced in the year 2022. So basically under general anesthesia, the surgeon wears loops and sits on the side that is opposite. The clicker is not working. Can you help? The surgeon sits on the opposite side of the patient's nostril in which the operation is being carried on, and the surgeon wears a pair of loops. And using a long nasal speculum, visualization of the area of the lacrimal sac is made possible. And a retinal light pipe is being introduced through the upper canaliculus, and this creates a trans-illumination target, which is the area where the lacrimal sac is present. Excuse me, just give me 1 moment. Okay. So basically, I'll just bring you through a quick rundown of the steps. So the retinal light pipe is introduced through the upper canaliculus and creates a trans-illumination target. And a myringotomy knife is introduced through the nasal entry and creates elliptical opening in the nasal mucosa. And ethmoid forceps is used to nibble away the mucosa, the nasal mucosa. And this is again a CT scan correlation of the anatomical landmarks that is pertinent in this surgery. And the bone is nibbled with the help of a 3 mm upward-facing kerosene ronger. And finally, an incision. So once the bone is nibbled away, we can see a tented entry where the lacrimal sac is present, and this is the lateral light pipe causing a tent against the lacrimal mucosa. And over here, the surgeon can make a direct incision using a meringotomy knife or a crescent blade used for cataract surgery. And this flap is actually peeled away with the help of an ethmoid forceps. So how are these value-derived outcomes important and relevant in current scenario? It's always a burden, not only in Singapore and every other part of the world, especially with what economic crisis that we are facing now with the recent changes in US administration and everything. It is important to reduce the healthcare costs everywhere. And whenever a new procedure is introduced, it is very important to assess and audit these procedures, not only in a clinical outcome based perspective, but also in terms of the costs and the processes that are involved. So basically, these VDO or value-derived outcome projects are undertaken in order to align all the resources to achieve the best possible healthcare outcome for the patients. One such example was of cataract surgery VDO project that was done again in Singapore in the year 2023, after which it showed a cost reduction for every single cataract surgery by at least 300 Singapore dollars. So a bit touch upon of how the healthcare financing in Singapore works. It is either public or private. All public, all Singapore citizens and permanent residents are covered by this public funds, which in short terms is called as single S and 3 Ms, which is subsidies, Medisave, Medishield, and Medifund, 4 tiers of subsidy based on the household's income. And for private, it is either pay out of your pockets or private insurances. So coming on to the actual study itself, we wanted to analyze the cost effectiveness of this non-endoscopic endonasal DCR as opposed to endoscopic approach. It was done as a part of a VDO project, and we analyzed the 2 groups. The first group was the used endoscopic approach. It was done between 2016 and 2023. So after oculoplastic surgeon B returned, he started introducing the non-endoscopic approach, and we looked at the costs between 2022 and 2023. In group A, the endoscopic one, it was performed along with an ENT surgeon. After obtaining our Chief Financial Officer's approval, we retrieved the data from the hospital records. As we've mentioned, patient's age, sex, the costs incurred by the patient during surgery, the number of ENT consult visits, and the costs incurred for that as well as the surgical time. There was no major difference in the age or the gender between the 2 groups, as well as the pre-op comorbidity index between the 2 groups. As you can see, the mean cost of the surgery for one non-endoscopic DCR in Singapore dollars was about 4,500, as opposed to an endoscopic approach, which costed about $9,600 per case. And the major part of the bar is occupied by the pink area, which is the actual surgical cost itself. And the yellow, if you could give me a couple of minutes, if you don't mind. The yellow bar on the top actually represents the consultation cost for ENT. And these are the things that we could actually target to reduce when we use the non-endoscopic approach. This is again a very busy graph, but I would like to bring the audience's attention to these 3 rows, where the consultation fees, consumables, and the surgery services were much lesser with the non-endoscopic or the direct approach as opposed to the endoscopic approach. This is again for endoscopic DCR, the number of ENT consultation visits that each patient went through. The orange part of the graph represents before surgery, and the blue one is after surgery. So there was a mean of about 1.12 visit before surgery and about 4.8 visits after surgery. In Singapore, we charge the patient about $120 for first visit, and for repeat subsequent visits, it takes about $70 to $80. And again, the operating time for non-endoscopic approach, it took about 82 minutes on an average, as opposed to endoscopic approach, where it took about 144 minutes. So what was deemed to be an advantage of the endoscopic approach is no longer an approach. It seems to be no longer an advantage, because the visualization can actually be achieved with the help of a pair of loops worn by the surgeon, as well as along with long nasal speculum. And the location of the lacrimal sac is actually a direct visualization through the transillumination target, as opposed to indirect landmarks that we use in endoscopic approach. And this can be variable if there are anatomical variations in the patient. And our approach is not something that's new. It was already described in 1990 in cadaveric projects. And again, instrumentation for endoscopic approach, it's very expensive, not portable, and it takes time to set up. And although there are potential advantages that you can use laser, drills, burrs using an endoscopic approach, but do they always give us a better advantage? One of our speakers already spoke us about ostium cicatrization and all that as failure of DCR, and we don't think all lasers and drills are going to be an advantage. And as non-endoscopic approach, all the instruments are very easily portable. The cost is very less and easy to set up. All the instruments that I've mentioned here, I've already discussed in the introduction section, which are very cheap and easily available everywhere. And the success rates, although it was not a direct measure of our project, we just wanted to compare what was in the studies regarding the success rates between the two procedures. In endoscopic, it was reported between 75 and 99. Actually, non-endoscopic doesn't seem to be falling any inferior to endoscopic approach, reported between 85 and 93%. And even in a recent review by Dr. Javed Ali, it was reported to be 84 to 96% in this review. So again, it is deemed to be a very cost-effective procedure without the need to purchase and maintain a scope and the cost involved with it. And we do not have to depend on an ENT surgeon. It can be done as a standalone procedure by an oculoplastic surgeon. And the learning curve for this is very, very shallow. And again, a surgeon could perform twice the number of cases in a single OT session using this non-endoscopic approach as opposed to an endoscopic approach. Thank you very much for the opportunity. I could take any questions if there are any on the stage. Thanks. Yes, ma'am.
What about the ease of surgery? The surgeon has to be always like in line with the nasal cavity in non-endoscopic approach. So what about the ease of surgery?
Well, it is definitely there, but the learning curve to master this surgery is much shallower. And compared to taking 2 hours, 2 hours plus to finish one endoscopic approach, this can be done within like 1 hour or so. I don't think it's a major concern from what I've seen my senior do and what I've tried to do under him. I don't think it's of a major concern to us.
Yeah. Okay, but still people, they prefer doing endoscopic, DCR. So I was wondering like why people are not doing non-endoscopic approach. There
Possibly
must be some reason, no, why it is not that popular.
I think it is slowly moving towards the east now. Dr. Javed Ali has also given quite a few talks about this non-endoscopic approach, and I'm not an expert in this, but I'm sure there's some advocacy going on about this non-endoscopic approach.
Yeah. Anyone, please? Yeah.
A few comments.
General anesthesia. Oh yes, intubation is done after surgery. Crawford's tube, we put in Crawford's tube. Yeah.
So about the position and why it is, so the reason I speak is because I was trained by Peter Dorman himself, so I know the surgery. I've been doing it for the last 10 years. I think the big advantage is, see, the lacrimal sac is very anterior. You don't need an endoscope to see it, and that you have highlighted very well. Why it is not as popular as endoscopic, there is very multiple reasons, partly awareness. Even today, very few know that the endonasal dacrocystorhinostomy can be done without an endoscope. So that's one. And to some extent, I think also industry plays a role there. But the question about, I had one question about this study per se. A lot of times when you look at a cost efficiency study, the challenge is not to find the direct cost, but the challenge is to find the indirect cost. That means in your particular cohort of 2 groups, if you find that one particular technique has the success which is not the same as another, that means if NEN DCR did not have the same success rates as endoscopic, even a few notches down, then it becomes to a lot of extra visits and procedures that are needed. Number 2, how much is the rehabilitation time? When do they go back to work? So cost efficiency studies are complicated by not only looking at the direct cost of the surgery, but also by the indirect cost, which is far more difficult to find because you can't find indirect costs unless you do a prospective study, where you are looking at what are the exact number of days out of work. Everything is part of the economics. So that's where. The fortunate part is, so that is very, very critical for your study. You should have also found out what is the time in which they have gone back to work and as much information related to that. And most importantly, you compared the endoscopic success on the historical. what was in your particular two groups, how's the success between A versus B is equally important. But the direct cost is definitely much, much cheaper compared to endoscopic. That we know. Thank you.
Definitely. Thank you, sir. For this particular presentation, we just wanted to highlight the direct cost. But again, as sir has mentioned, it is important to have a look at the indirect cost as well, which we have some data, but we didn't really want to put it in these slides. And so it was mainly for the CFO's office of our hospital that we had to project to them that this is, these patients are incurring much lesser costs to do this kind of surgery. So the earlier procedure, endoscopic, is now all being replaced by this surgery. So we had to prove to the CFO of the hospital that this is a better a way of getting things done. So that was the ultimate aim of the cost effectiveness study. Yes, ma'am. No, ma'am. Oculoplastic surgeon. For an endoscopic approach. Together with an oculoplastic surgeon. Yes, exactly. That's where the cost shot up. That's another way of looking at things. Thanks, ma'am.
I have one comment on the other side of things. Like Dr. Surya added about the non-endoscopic thing. See, my point is that the equipment purchase is usually once. That cost is usually once, and it's divided over many patients. You get well trained in doing endoscopic DCRs. You can do it in 20 to 25 minutes and not like 100 minutes or 100 and more than 100 minutes. Your time would... Yeah, I'm saying
yeah.
If you get well trained, then you can do it in 20 to 25 minutes. Apart from the GA time, I'm not counting that, but the actual surgical time, I'm not talking about my time, I'm talking about Dr. Javed. I've seen him operate. So he does it in 20 minutes, 25 minutes. And so time saved is better, that is even less than your non-endoscopic time. And if it is really about cost and it's really about time and it's really about oculoplastic surgery, then I think why not external DCR? What is wrong with it?
This is another debatable topic, you know.
So if you are trying to avoid the scar, I don't think time is fair enough that you're comparing 100 minutes with a 40 minutes time on this side. That depends on the surgeon to surgeon. If you get well trained, you can manage the time. Cost is once, that is divided.
Yeah, just very quickly, one comment, Vikas, is that if you compare it with external DCR, the indirect costs will dramatically change. Because very rarely, any of us who do externals, very rarely you would see the patient go back to work in 2 days' time. And that's where the difference comes in.
But you will also be doing it under local anesthesia.
Local.
Correct. But you know the
yeah, that is also right. So as I said, it's we can have a long debate on
that's where the debate is, and that could be the difference. The indirect costs are different. The direct costs are different. But you're comparing endoscopic to non-endoscopic and not to external. So.
Thanks
even
for
oculoplastic surgeon versus ENT surgeon. Okay.
Thanks for all the inputs.
Thank you very much.
Really very interesting.
Yeah, wonderful discussions. Thank you. Okay, and finally, our last presentation of the session, Dr. Susant Adiga, with his talk, Diverse Presentations of Orbital Tuberculosis.
Yes, thank you, ma'am. Good afternoon, everyone. So today I'm here with a short presentation. It's titled The Master of Disguise, Diverse Presentations of Orbital Tuberculosis. So as we all know, tuberculosis is caused by Mycobacterium tuberculosis, and it's an infectious disease that can be either pulmonary or extrapulmonary. So orbital tuberculosis is a rare manifestation of the extrapulmonary type, and it mainly arises from the hematogenous route. Also, it may be caused as a direct extension from the paranasal sinuses. So why is it called the master of disguise? It's because tuberculosis can affect nearly any ocular tissue. So it can affect the orbit, it can affect the lacrimal gland, the eyelid, the conjunctiva, the sclera, the cornea. It can be anywhere and everywhere. But we normally don't think of TB in a normal clinical scenario. So in each and every case, a high index of suspicion is needed. So this was a study conducted at our institute. We did a one-year retrospective single-center case series, and all these patients underwent a detailed ophthalmic and medical evaluation. So our first case, this is a 6-year-old female child who presented with mild proptosis, 1 millimeter right eye proptosis, with a 2-line drop in best-corrected Snellen's acuity. An examination revealed optic disc edema and a retinal striae. So we normally think that there's an orbital mass that's compressing the globe. So we went for a CT scan, and it showed an isodense lesion surrounding the right optic nerve. So a lateral orbitotomy was done, which revealed a pus, which was drained and sent for evaluation. So histopathology in this condition revealed necrotizing granulomatous inflammation, which was consistent with TB. So another case, we had a 21-year-old female patient who had right eye pain and double vision, only for 2 months duration. It was associated with proptosis and exotropia. So in this case also, we went for a scan, which showed diffuse thickening of the extraocular muscles. So normally, when we see that the muscles are so enlarged, we normally think of an infectious disease, rarely, but usually thyroid eye disease, or specific or non-specific orbital inflammation. So we are not sure of the diagnosis. So we did a medial orbitotomy was performed, and a biopsy was taken from the medial rectus muscle. And in this case, too, it showed a necrotizing granulomatous inflammation, which was consistent with TB. So another case was a 73-year-old gentleman who had a 16-year history of subbrow mass that had recently enlarged over 3 weeks. So it was a non-tender cystic mass, which was attached to the bone, causing inferior globe dystopia. So normally in this scenario, we might think of a very long-standing dermoid or some mass in the lacrimal gland. So we are not sure of the diagnosis in this case as well. So we went for an anterior orbitotomy. And in this case too, we got necrotizing granulomatous inflammation, which was consistent with TB. So our fourth case was a 14-year-old boy who had left eye proptosis since 8 months. So in his previous history, he had a prior maxillary sinus biopsy, which showed TB, and the patient was on ATT currently. We went for a repeat CT scan, in which showed an ill-defined lesion in the left maxillary sinus, which was extending into the orbit. So in this scenario, maybe we would think of an invasive fungal infection or some tumor, some mass, which is extending from the paranasal sinuses. So in this case, too, we went for a surgery, and debulking of the lesion was done, and pus was drained. So as we can see, I'm not sure if the video is clear, but here we can see that there's just a gush of pus, and all the pus has come out. So even in this case, we got a similar result, and which was consistent with tuberculosis. So all these cases, further testing was done, MON2 was done, chest x-rays were done, and we sent the patient for infectious disease experts evaluation. So we conducted further tests where needed. So in the first 3 patients with us, they were started on intensive phase of ATT for 2 months, with adjustments were made based on the response, and then they were shifted to the continuation phase. But the fourth case, since the patient was already on ATT and the patient was not improving and the disease was increasing, we switched to a multi-drug TB regimen after gene expert testing. So at 3 and 6 months follow-up, all the patients showed improvement, which included that reduction in proptosis and symptom relief. So hence, imaging, particularly CT scans, are done is the preferred initial investigation, though biopsy confirmation is essential in all these patients. And biopsy usually shows a necrotizing caseating granuloma or a microbiological evidence, which is good if you find one. So ancillary tests like MON2, quantiferin TB Gold, chest X-ray, or the gene expert testing, they provide supportive evidence. But there's no definitive criteria which helps us in diagnosis this is orbital TB. So it's just a hit and trial. So if you think that all the criteria are meeting, and if you think it's TB, so you can start on ATT, and a positive response to this ATT regimen usually confirms our diagnosis. So TB, often called the great mimicker, the master of disguise, can be very challenging to diagnose, and it can present as anything and everything in the eye. So however, a high index of suspicion is needed. With thorough workup, early diagnosis can be achieved. So when ATT is started early, with proper patient adherence, the prognosis in these patients are that they are generally good. Hence, in TB, you need to spot the unseen to solve the puzzle. Thank you.
Thank you. Wonderful. So, does anybody have questions?
So I think TB is something which can affect any age group, can have any kind of presentation at any location. So you rightly said that it's a great mimicker.
Yes.
Thank you so much. Any comments or any, yeah, please. Use the mic, please. Yeah,
yes,
family
exactly,
history, did you take family
yes,
history?
Yes,
So,
but except one case, except the fourth case, none of the other cases had positive family history.
and
But
any
the
systemic tuberculosis
no,
in
ma'am.
any of your patients?
In none of them. None of them had pulmonary TB. for longer duration. No, ma'am. We generally give it for at least 10 to 12 months. It's a long duration of treatment. Yes, ma'am. Yes, ma'am. If bone involvement is there, yeah, true. Yes, ma'am. Yeah, thank you, ma'am. Yeah. Okay. Yes, ma'am. Institute, yeah. Yeah, sure, ma'am. Sure, ma'am. So this study was conducted in Nepal. And in Nepal, the setup and all, it's kind of expensive. So, yeah, sure. Thank you, ma'am.
Wonderful study.
In our series, we didn't find any HIV relationships. Yeah, yes.
Okay. Excellent presentation.
Sure.
Thank you,
you so
Doctor.
much. Yeah.
Thank you.
Thank you.
Wonderful. So thank you for all the presenters for your excellent talks, and thanks to the audience for your attention.
We can announce these three again if they are there.
So is there
Dr.
any
Irfan,
Dr. Irfan? Is there?
Dr. Rangarajan,
Dr. Rangarajan?
and
No.
Dr. Dean.
Dr. Dean? No. Okay.
Okay.
So.
All right, you can. Yeah, we have to actually give away these mementos. If these doctors are available here, please come forward. Dr. Priyanka Gupta. Dr. Priyanka Gupta is here. Dr. Preeti. Dr. Preeti. Jayabal. Come, you can.
Thank you.
Present.
Yeah, thank you.
Yeah. Come, please come this way. Dr. Naveen and Dr. Deshpande.
Dr. Nibi.
Dr. Deshpande? No? All right. Okay. So please come forward for the group picture. All the speakers, all the eminent experts, speakers, please come forward.
Oh, we were here. Okay. I think it's
Priyanka Gupta.
Priyanka. Oh, no, Priyanka. No, Priyanka. Okay, no, Priyanka. Okay. So is there? Dr. Priyanka.
Thank you for assisting very much.
Nibi.
Very, very thanks.
You have a